Good morning, ladies and gentlemen. Today's lecture is on two topics. The first one is mixed connective tissue disease, and the second one is on cutaneous manifestation of rheumatoid diseases. So first, the mixed connective tissue disease. Mixed connective tissue disease, or the overlap syndrome, describes the clinical situation in which symptoms of number of connective tissue diseases occur in one patient. This can occur at one time or at different times, but it is considered to be a mixture of different connective tissue diseases. There are specific antibody profile associated with this condition. And the typical antibody which is seen in mixed connective tissue disease is anti-U1-RNP. The more variants are described, both with and without U1-RNP antibody, of the Sharp's original description about the mixed connective tissue disease. Progress to a specific connective tissue disease may occur, but many patients continue to have mixed and static pattern of symptomatology. So you can say that the mixed connective tissue disease is an overlap of symptoms of different connective tissue disease. It is considered as a separate entity by virtue of its peculiar antibodies, that is anti-U1-RNP. But however, several variants are also seen. Some authors regard mixed connective tissue disease as among many undifferentiated connective tissue diseases or overlap syndromes. It is important to recognize this group of patients because of generally good prognosis and response to corticosteroid therapy. So compared to other fixed connective tissue diseases like systemic sclerosis, like dermatomyositis, or like SLE, the prognosis of patients suffering from mixed connective tissue disease is quite good, and the response to treatment is also satisfactory. Despite of various efforts, there is no set diagnostic criteria for the mixed connective tissue diseases. Some associations are more frequent than others. For example, systemic sclerosis and dermatomyositis combination is more often seen in mixed connective tissue disease as compared to systemic sclerosis and SLE combination. Epidemiology, the incidence and prevalence. In a Norwegian study, point prevalence of adult mixed connective tissue disease was 3.8 per 100,000 adults. Age, mean age of diagnosis of adult onset mixed connective tissue disease is 37.9 years. The condition can occur in children and may be more severe, in whom we means that in children there is more chances of getting cardiac and renal disease, thrombocytopenia, and arthritis. Female ratio male is around 3.3:1. Pathophysiology and autoantibodies. In the classical form of mixed connective tissue disease, all patients have speckled type of anti-nuclear antibody together with high titer of ENAs. U1-RNP may be associated with different clinical variant and is considered to be the most prototype antibody of this disease. In addition, Rho and La antibodies are found quite frequently. Then PM1 and KU occur in systemic sclerosis polymyositis overlap, while SLKI antibody is seen in SLE, systemic sclerosis, and Zika syndrome overlap. Complement levels are normal in mixed connective tissue diseases. Anti-DNA antibody titer is low, but disappear with corticosteroid therapy. Anti-endothelial antibodies are seen in 50% of the cases. And such antibodies are associated with abnormal pulmonary, neurological, and cardiac functions, and also result in spontaneous abortions. The basic histology of mixed connective tissue disease is similar to other autoimmune disorders, which is of interface dermatitis with effacement of reticulars, basal cell degeneration, pigmentary incontinence, and cytoid bodies formation. So the basal layer is not existent here, and these are the cytoid bodies. Later, the morphia-like features predominate with dense dermal sclerosis that extends deep into the subcutaneous fat. Genetics. Different HLA antigens between patient with mixed connective tissue disease and SLE indicates that these two are different disorders. HLA-DR4 is found more common in patients having arthritis in mixed connective tissue diseases. Familial cases also occur. Environmental factors. Ultraviolet radiation may be relevant in exacerbating the lupus-like elements of mixed connective tissue disease. Vitamin D deficiency is also associated. The role of silicone breast implant in pathogenesis is controversial. So practically, you can say that ultraviolet light can aggravate the SLE-like features in mixed connective tissue disease, and vitamin D deficiency is associated. Clinical features, history, and presentation. The usual presentation is with joint symptoms, Raynaud's phenomena, and skin changes. The skin changes can be either erythematous skin rash, like in SLE or dermatomyositis, or skin swelling and thickening like we see in systemic sclerosis. Patient will show features of SLE, systemic sclerosis, dermatomyositis, and polymyositis in various combinations. But you can say that full-blown disease is not seen in mixed connective tissue disease. Partial features are seen of different diseases. Raynaud's phenomena, arthritis and arthralgia, and swelling of dorsa of hands are common presenting features. More than half have abnormal nail fold capillaries. There may be autonomic neuropathy or neuropsychiatric features. Less frequent features are orogenital ulcers and paniculitis. Features may lead to diagnosis of a single connective tissue disease or remain mixed throughout the course of the illness. So it is a beautiful mixture of different connective tissue diseases in which partial features of each connective tissue disease is seen, and none of the feature is severe and none of the feature is complete of a specific connective tissue disease. Among the differential diagnoses, any specific connective tissue disease need to be considered in the differential diagnosis, like dermatomyositis, SLE, or systemic sclerosis. There is no set pattern of staging of severity in mixed connective tissue diseases. Complications and co-morbidities. Mixed connective tissue disease is generally considered to be a disease with good prognosis. However, thrombocytopenia is occasionally found. Livedoid vasculitis, ankylosing spondylitis, and anti-neutrophilic cytoplasmic antibody-related glomerulonephritis is reported to occur. There may be increased risk of malignancy in 10% of the cases, which is much lower as compared to dermatomyositis. Peripheral gangrene may occur due to obstruction of small blood vessels. The presence of anti-RNP is associated with good prognosis. Death in 4% from pulmonary hypertension, nephritis, myocarditis, or widespread vasculitis. 1/3 cases develop into characteristic connective tissue disease, usually SLE or systemic sclerosis. So if we follow such patients for a long period of time, these patients may end up into one of the specific connective tissue disease with full-blown features. Investigations. Autoantibody testing is fundamental. We will go for anti-nuclear antibody, anti-double stranded ENAs, and especially U1 RNP. Investigations of potential internal organ involvement should be done as a routine assessment of renal and pulmonary functions, and assessment for abnormal esophageal motility or myositis. Management. First line treatment is always oral steroids, which should be used early in a dose of 0.5 milligram per kg with rapid reduction of dose when the symptoms settle. Symptomatic treatment for particular symptoms is needed. For example, vascular symptoms should be treated with oral or intravenous vasodilators. Second line agents are rarely used, but sometimes we may have to consider the option of giving hydroxychloroquine and methotrexate. Hematological manifestations may need to be managed by anti-B cell treatment. Renal and neurological disease may require treatment with plasmapheresis or more aggressive immunosuppressive therapy, but usually such eventuality does not occur. Now coming to the second part of today's lecture, that is the dermatological manifestations of rheumatoid diseases. Introduction. The following conditions are to be discussed here. The first, the skin diseases which are related to rheumatoid arthritis, Still disease, Sjögren syndrome, and rheumatic fever. Rheumatoid arthritis. Rheumatoid arthritis is a common destructive arthropathy associated with number of systemic symptoms and often associated with number of characteristic skin problems. In this lecture, we are not going to discuss the features of rheumatoid arthritis, but we will be discussing the skin manifestations associated with rheumatoid arthritis. And the different skin features associated include the first and foremost, the rheumatoid nodules, rheumatoid vasculitis, Felty syndrome, pyoderma gangrenosum, interstitial granulomatous dermatitis with arthritis, palisaded neutrophilic and granulomatous dermatitis, rheumatoid neutrophilic dermatitis, juvenile rheumatoid arthritis, and adult onset Still's disease. The distinction of rheumatoid arthritis with skin involvement from systemic lupus erythematosus may be difficult, and a skin biopsy for immunofluorescence studies is helpful because SLE is associated with rheumatoid-like features, and the skin manifestations of rheumatoid arthritis are very similar to the skin manifestations in SLE. In rheumatoid arthritis, fluorescent at dermoepidermal junction is not found, even in cases when there is high titer of anti-nuclear factor. Pseudosclerodermatous change, particularly of hands, occur in rheumatoid arthritis, and there are common incidences of overlap syndromes. Epidemiology. Rheumatoid arthritis is quite a common condition occurring in 1% of the adult population. Some problems such as rheumatoid nodules and vasculitis are well recognized and common and occurring in 20% of patients suffering from rheumatoid arthritis. Rheumatoid arthritis is mainly an adult disease with the age of presentation at 30 to 40 years. Sex. Rheumatoid arthritis, like other autoimmune disorders, is more common in women, but the occurrence of rheumatoid nodules is relatively commoner in males. Rheumatoid nodules. Rheumatoid nodules are palpable subcutaneous nodules which occur in approximately 20% of the patient. The most common site is on the ulnar border of the forearm, but can also occur in areas subjected to pressure such as sacrum, buttocks, and heels. They vary in size from 2 to 3 millimeter up to several centimeters, are firm in consistency, and tend to ulcerate with trauma. Lesions may rarely occur on sclera, where it is called as scleromalacia, and may perforate, calling as scleromalacia perforans, that may lead to complete blindness. You can see multiple small yellowish nodules on the fingers in this patient. Nodules are also seen at the extensor surface of the elbow and even on the pinna. These nodules are little ulcerated as well. Sometimes there are numerous violaceous papules with centripetal scaling. There is a variant which is called as the rheumatoid nodulosis, may precede rheumatoid disease, characterized by multiple small nodules occurring on hand and feet with palindromic rheumatism, that is phasic rheumatism, and little evidence of synovitis. Nodules may be found in other organs, particularly the lungs. Nodules are invariably associated with severe form of rheumatoid arthritis, and rheumatic factor and anti-nuclear factor is frequently found in such patients. Such nodulosis may be precipitated by drugs, including methotrexate and biological agents. The rheumatoid nodules classically occur in subcutaneous tissue or lower reticular dermis. Otherwise, the histology is similar to granuloma annulare. There is a well-localized area of necrobiosis with palisading granuloma. And the classical appearance is occurrence of this palisading granuloma deep in the reticular dermis or in the subcutaneous fat. Here, there is massive scarring seen in the subcutaneous fat. The necrobiotic connective tissue surrounded by a well-developed histocytic and lymphocytic palisade. Vasculitis can occur in rheumatoid nodules and papules. The histological features have many common findings of granuloma annulare. Differential diagnosis. The subcutaneous nodules or rheumatic fever looks like rheumatoid nodules, but there is fibrinoid material and edema of collagen, but there is little infiltration of with fibroblasts, histiocytes, and lymphocytes. Nodules from still disease, which is juvenile rheumatoid arthritis, resembles those seen in rheumatic fever. And another possibility of erythema elevatum diatinum must be considered because it is sometimes coexistent with rheumatoid arthritis. Then another skin manifestation of rheumatoid arthritis is the linear subcutaneous band and interstitial granulomatous dermatitis. Elevated subcutaneous bands, 3 to 5 millimeter wide and 10 centimeter or more in length, have been described in patients with rheumatoid arthritis with nodules. Histologically, the bands show changes similar to the nodules with interstitial granuloma formation, but there is no evidence of vasculitis. The bands are firm, non-tender, papular, and adherent to the skin, and seen in axilla extending to the iliac crest. You can see these bands, which start from the axilla and move down to even the pelvic crest, involving the pelvic crest. Rheumatoid neutrophilic dermatosis. In patients with severe arthritis, symmetrical erythematous nodules and urticaria-like plaques occur on dorsa of hands and arms, extensor aspects of the joints, back of neck, scalp, and trunk. Sometimes they are tender, they ulcerate, and vesiculation may occur. Histology is quite different from rheumatoid nodule. And histology, there is dense diffuse infiltration of neutrophils in the dermis, papillary microabscess, leukocytoclasia, but no vasculitis. So in histology, rheumatoid neutrophilic dermatosis resembles pyoderma gangrenosum and Sweet syndrome. Dapsone, either alone or in combination with colchicine, may be advised in the treatment. These are the multiple small nodules which are not firm and not discrete like rheumatoid nodules. So this is seen in patients of rheumatoid arthritis. So such a rash in patients of rheumatoid arthritis with histology which looks like Sweet syndrome should be labeled as rheumatoid neutrophilic dermatosis. Then vascular lesions. Vascular lesions in rheumatoid arthritis are well recognized, although the Raynaud's phenomena is uncommon. Most characteristic lesions is of arthritis in rheumatoid patients, small infarcts along the nails, and sometimes apex of cutaneous, sometimes at the apex of small cutaneous nodules. The pulp of the fingers may show small, painful, purpuric nodules. This is called as the by-water lesions. Purpuric nodules, which are painful and small on the pulp of the fingers. Lesions are usually transitory and last for 2 to 3 days, rarely bully occur. Skin may show painful purpuric and necrotic lesions that may get hemorrhagic and ulcerate. Ulcers, if formed, are well defined with surrounding bluish halo. Healing occurs quite slowly with scarring. Gangrene may sometimes extend to involve the large part of the foot or hand, and within a few days. The occurrence of digital necrosis is closely correlated with presence of rheumatoid factor and rheumatoid nodules. Arthritis involving GI tract causing abdominal pain and which results in ischemic ulcers, gangrene of the bowel, intraperitoneal hemorrhages, and splenic infarction. So these all are complications. Anticardiolipin antibodies are sometimes demonstrated in patients with vasculitis. Histology is like leukocytoclastic vasculitis. Palmar erythema is common and non-specific. So all sort of vasculitic lesions, especially on the pulp of the fingers, is seen in rheumatoid arthritis. Leg ulcers. Vasculitis is a factor in 18% of rheumatoid patients. Venous insufficiency and postural factors contribute to another nearly half of the patient presenting as leg ulcers in rheumatoid arthritis. Trauma, pressure, and arterial insufficiency are also the major contributing factor. Arthritic ulcers are commoner in male and usually deep and punched out, slow healing, and start as frank, purpuric, or nodular lesions. Leg ulcers are more common in Felty syndrome, which is a combination of leg ulcers with arthritis, splenomegaly, and leukopenia. So in case of leg ulcer, which is usually of arterial in origin and associated with arthritis, you must consider the diagnosis of Felty syndrome. Livedo reticularis is seen to occur in rheumatoid arthritis. Peripheral sensory and motor neuropathy may occur due to vasculitis of vasa nervosa. Other dermatological associations. Rheumatoid arthritis is associated with bullous pemphigoid, pemphigus vulgaris, pemphigus foliaceus, and dermatitis herpetiformis. Subcorneal pustular dermatosis and EBA, yellow nail syndrome and acquired cutis laxa, and erosive pustular dermatosis of the scalp. Fibroblastic rheumatism. Fibroblastic rheumatism is an entity that occurs in all ages and affects both sexes equally. Clinically, it starts suddenly with symmetrical polyarthritis and cutaneous nodules. The nodules are 5 to 20 centimeter in diameter, that in size they are bigger than rheumatoid nodules and occur before the onset of arthritis. Occur on both surfaces of hands, that is dorsal and palmar, usually over the joints and elbow, knee, ear, and neck. They are smooth, firm, and skin colored, resolve spontaneously in 6 months to few years. The histology of these fibrotic rheumatism nodules show the proliferation of spindle cells and dermal fibrosis. There is no necrobiosis which is seen in rheumatoid nodules. And these spindle cells have myofibroblastic differentiation. These are the fibrosing rheumatism nodules. Raynaud's phenomena, sclerodactyly with inability to join the palms, joint effusion and stiffness are frequent. Systemic involvement does not usually occur and all lab tests are negative. Joint erosions may develop and change tend to persist despite of treatment. Other rheumatoid diseases. Still disease. Still disease is also known as the juvenile rheumatoid arthritis. Juvenile rheumatoid arthritis has features which are different from the usual rheumatoid arthritis. The characteristic rash is seen in approximately 25% of the patients of still disease with male predominance. And this rash consists of a non-pruritic, salmon pink, macules or papules, up to 3 to 5 mm in diameter with slightly irregular margin. Larger lesions show central or surrounding pallor. This rash is seen on limb and trunk, but sometimes occur on face and neck. Rash lasts only a few hours, characteristically appearing in the midday and associated with increased temperature of the patient or the environment. This rash of Still disease is common in patients having fever, splenomegaly, lymphadenopathy, and raised ESR. This is a rash, which we see in Still's disease. Otherwise non-specific, but if seen with other features of arthritis and splenomegaly and lymphadenopathy, then it is called, it may be labeled as a rash of Still's disease. The rash appear in first 2 weeks of the disease may precede manifestation up to 9 years. The rash occur intermittently for many years and has no prognostic value. Histology. There is mild infiltrate, sometimes with neutrophils and lymphocytes perivascular. The rash fades as the disease settles and the steroids do not have any specific effect on the rash. The rash is distinguished from erythema marginatum by a smaller size of the lesions, their occurrence on the face, and the lesions are at their greatest size at the onset. Subcutaneous nodule also occur in Still disease. The histology of subcutaneous nodule in Still disease resembles that of rheumatic fever rather than rheumatoid arthritis. Adult Still disease. And such case patients have features of juvenile rheumatoid arthritis. In addition, white cell count is raised and rheumatoid and anti-neutrophilic antibody and anti-nuclear antibody factor are usually absent. Both sexes are equally involved. Similar rash of salmon pink color may occur on proximal limb, trunk, and face. Alopecia is further a feature. The rash is an adverse prognostic indicator in adult Still disease. 1/3 of the cases remit, 1/3 become chronic, and rest have intermittent course. So both the Still diseases carries a rash, which is maculopapular with salmon pink color. Rash in juvenile Still disease does not have any prognostic significance, but rash in adult Still disease has bad prognostic indicator. Treatment is with aspirin and other non-steroidal anti-inflammatory drugs. Systemic therapy including corticosteroids, oral gold, methotrexate, and biological agents like anakinra, which is anti-interleukin-1 RA, or tocilizumab, anti-interleukin-6 may be required. Sjögren syndrome. The Sjögren syndrome is characterized by clinical symptoms of dryness of eyes, mouth, and skin due to exocrine dysfunction caused by inflammation of the glandular structures. It is usually anti-nuclear antibody and Rho or SSA positive. In primary disease, there is no association with other connective tissue diseases, while secondary diseases, such an association with other connective tissue diseases is found. The most common feature of this condition is dryness and atrophy of the conjunctiva and cornea, which is called as the keratoconjunctivitis sicca, and dry mouth, which is called as xerostomia. Malignant lymphoma is associated with primary form of the disease with 40-fold increased risk, the majority of being a B cell origin. Lymphadenopathy, parotid gland enlargement, palpable purpura, low C4 serum levels, cryoglobulins have been associated with development of non-Hodgkin lymphoma or lymphoproliferative diseases. Revised classification criteria for Sjögren syndrome. There are 6 different criteria in which few are objective and few are subjective criteria. Ocular symptoms. At least one of the following 3 symptoms should be present: dry eyes for more than 3 months, sensation of sand or gravel in the eyes, and need for tear substitutes more than 3 times a day. This is a subjective criteria. Then oral symptom, another subjective criteria. At least one of the following 3 oral symptoms are present: dry mouth for more than 3 months, recurrent or persistent swollen salivary glands, and need liquid to swallow dry food. Then ocular sign. This is an objective symptom. At least one of the following two tests be positive: the shimmer test performed without anesthesia and Rose Bengal score. These tests will check the lacrimal secretions. Histopathology. In minor salivary gland, there is focal lymphocytic salloadenitis. Salivary gland involvement is checked in the fifth criteria. A positive result of at least one of the following diagnostic tests: unstimulated whole salivary flow less than or equal to 1.5 ml in 15 minutes. Then parotid salography show the presence of diffuse sialactasis without evidence of obstruction in main duct. That is, the flow of saliva is slow, but there is no evidence of any occlusion. Salivary scintigraphy show delayed uptake, reduced concentration, and decreased secretion of the tracer. Autoantibodies, another subjective criteria, objective criteria. Presence of serum autoantibodies of Rho or La or both. So for a primary Sjögren syndrome, in patient without other associated connective tissue disease, presence of any 4 of the 6 items above, so long as either item 4, histopathology, or 6, serology is positive. That is, if any 4 of these 6 items are positive, but at least this among the 4, at least one of them is histology or autoantibodies, then it may be called as the primary Sjögren syndrome. Or presence of 3 of the 4 objective clinical criteria. That is, if from 3, 4, 5, 6, these 4 which are the objective criteria, if any 3 are present among the 4, then it can be labeled as primary Sjögren syndrome. Secondary Sjögren syndrome. In patient with other associated connective tissue disease, item 1 or item 2 plus any 2 of the among items 3, 4, and 5 may be considered as indicative of secondary Sjögren syndrome. That is, for secondary Sjögren syndrome, in which other connective tissue diseases are associated, either ocular symptoms or the oral symptoms. In either ocular or the oral symptoms plus any of the any two of the objective signs among 3, 4, and 5. That is either an ocular sign or histopathology or salivary glands. And among these, any 2 of the sign is positive. 2 of the signs among 3, 4, and 5, and either 1 or 2. So this is a criteria for secondary Sjögren syndrome. You have to just remember it and understand it because it is not easy to explain. So I would like to explain it again. For primary Sjögren syndrome, in which there is no associated connective tissue disease, any 4 of the 6 symptoms or 6 criteria should be positive, and among these 4 criteria, at least histopathology or autoantibody must be positive. Or the second criteria is presence of any 3 of the criteria among the 4 objective criteria, which is 3, 4, 5, and 6. So any 3 among the 4 objective criteria. For secondary Sjögren syndrome, either sim 1 or 2, or any 2 among the 3, 4, and 5. Any 2 among 3, 4, and 5. Epidemiology. Secondary disease occur in around 15%, of the most connective tissue diseases. Secondary disease. That is, it is quite associated with other connective tissue diseases. The onset occur most frequently in 4 to 6 decades. Primary Sjögren syndrome is rare in childhood. 91% of the patients with primary form are women. Pathophysiology. The key cells and molecules involved are the glands, Prominent feature of Sjögren syndrome is B cell hyperactivity. There is periductal and perivascular infiltration of the salivary and lacrimal glands by lymphocytes and plasma cells, leading to apoptosis of acinar and ductal epithelial cells. Inflammation in established disease is predominantly Th1 mediated, but B cells have a significant role. Recent studies have shown that anti-muscarinic receptor antibodies interfere with secretory effect of the parasympathetic neurotransmitters. Genetics: increased incidence of HLA B8 and DR3. DR4 is more commonly associated with syndromes occurring with rheumatoid arthritis and Raynaud's phenomena. Clinical features: most patients present with dry mouth or dry eye. 43% patients present with dry eye were found to have keratoconjunctivitis sicca and xerostomia. And 23% have associated connective tissue disease, particularly the rheumatoid arthritis. So the association of Sjögren syndrome with rheumatoid arthritis is most common. Some cases present with generalized or anogenital pruritus. A reduction in appreciation of taste and smell is observed. Infection including pneumonia, oral candidiasis, and bacterial conjunctivitis are frequent. Skin findings: skin involvement occur in 50% of patients with Sjögren syndrome. Annular erythema that occurs is subdivided into 3 clinical types: sweet disease-like annular erythema with elevated borders, subacute cutaneous lupus erythematosus like marginally scaled erythema, and papillary erythema. So sweet syndrome-like rash, then SCLE-like rash, and the papillary erythema. It is non-scarring and non-photoaggravated. Nail fold capillaries are normal. Non-thrombotic purpura may occur in crops. Inflammatory and necrotizing vasculitis can occur. Nail fold infarct, splinter hemorrhages, and gangrene of finger are all uncommon findings. Mouth: the saliva is first thick and mucoid, but salivary volume decreases. Tongue is red, smooth, and dry. Parotid duct narrowing and web formation develops, but it is not obstructed. Dental caries are often severe because of lack of saliva and progressive, and chronic candidiasis is common. Lips are red, dry, and scaly. A recurrent episode of swelling of one or both parotid gland, or less often submaxillary and sublingual glands. Other mucous membranes: atrophic changes in mucous membranes of upper respiratory tract lead to nasal crusting and dryness. Recurrent episodes of infection, hoarseness, and aphonia. Pulmonary infiltration, atelectasis, and fibrosis may occur. Digestive symptoms attribute to atrophy of gastric mucous membrane and achlorohydria. Vulva, vagina, anus, there is dryness and pruritus. Non-cutaneous features: approximately 70% of Sjögren syndrome suffer from disabling fatigue. There is mild articular symptoms as mild synovitis. Cervical and generalized lymphadenopathy and enlargement of liver and spleen. Main renal abnormalities like interstitial nephritis, renal tubular acidosis, and high prevalence of fetal loss. So in patient of Sjögren syndrome, always examine the lymph nodes and abdomen for the liver and spleen. Differential diagnosis: infection, salivary stones, tumor of parotid gland, nasal allergy, and inflammation. Complications and co-morbidity: potential complications are cerebral vasculitis, renal disease, and lymphoma. The disease is chronic but variably progressive. Patients have minor persistent sicca syndrome, but others will suffer from more severe and variable disease. 1 in 5 patients with Sjögren syndrome die of lymphoma. So the incidence is around about 20%. Investigation: hypergammaglobulinemia, rheumatoid factors are common. Anti-nuclear antibody is present in more than 50% of the cases. Anti-DNA antibodies in occasionally demonstrated, but anti-SM and anti-RNP antibodies are never found. In Sicca syndrome alone, can be found in overlap syndromes. Antibody to Rho were found in 53% of patients, and La is also found in quite a large number of Sjögren syndrome patients. Anti-Rho antibodies are particularly associated with vasculitis, purpura, lymphadenopathy, and hematological and serological abnormalities. Recurrent annular erythema is associated with anti-La antibodies. Treatment. Symptomatic treatment of dryness of eyes is best accomplished by lubricating agent like 0.5% methyl cellulose eye drops instilled frequently. Artificial saliva can be prescribed, steam inhalations, air humidifier. Systemic corticosteroids are effective in reducing parotid swelling, but rarely increase parotid or lacrimal secretion. Chloroquine and hydroxychloroquine sulfate by mouth have been found useful. Cyclosporin improves subjective xerostomia. Annular erythema is controlled by prednisolone or by dapsone, and hope for B-cell direct therapies include rituximab. So most of the treatments will not be able to restore the normal parotid, normal salivary and lacrimal secretions. Rheumatic fever. Erythema marginatum is the characteristic rash of rheumatic fever, which occur in 25% of the cases. This rash is an evanescent, asymptomatic, pink superficial semicircles or rings, which disappear without scaling or pigmentation in few days. Histology, there is perivascular infiltration of neutrophils and lymphocytes. It is similar to other annular erythema. Erythema multiforme, petechiae, and urticaria may sometimes be found. Livedoid reticularis have been reported. Subcutaneous nodules occur particularly in the occiput, wrist, and back of forearms. That is distinguished from the rheumatoid nodules because there is no necrobiosis associated with these nodules. So I thank you all for a patient listening.